Thank you for joining Cancer Support Community Atlanta for Managing Sleep During Stressful Times, featuring Dr. Scott Leibowitz with Northside Hospital Sleep Medicine and Laureate Medical Group.
Dr. Scott Leibowitz is a fellowship-trained physician and board certified in sleep and internal medicine and has over a decade of experience. He graduated from the Medical College of Georgia, completed his residency at the University of Colorado Health and Sciences Center, and completed his fellowship at the Stanford Center for Sleep Sciences and Medicine. He's currently practices with the Laureate Medical Group and serves as the medical director with Northside Hospital Sleep Medicine.
Thank you guys for having me. This is a talk, really it's, while it's focused on patients with or previously diagnosed or treated for cancer, I really kind of am taking the approach is this is really more a broad discussion on sleep in general, because I think it's applicable across the board, irrespective of disease states or conditions or treatments and so forth, because I think it really is applicable to everybody in every situation, because it holds true. So to start, the things that I see in my clinic are common complaints, which include difficulties falling asleep, waking up a lot at night, difficulties falling back asleep when people wake up, people waking up tired, feeling sleepy during the day, or feeling fatigued or tired. And it is important to sort of differentiate the sleepiness from fatigue. And so sleepiness is the tendency to fall asleep when sedentary or unengaged, or overwhelming need to sleep, or the ability to fall asleep when given the opportunity. Whereas fatigue is more of a listlessness and a lethargy and a kind of a general got nothing. And you could be fatigued and not sleepy, or you could be sleepy and not fatigued, or you could be both. And so when people are just sleepy and not fatigued, largely they stay engaged and active, and generally they don't recognize being sleepy. Whereas if you're fatigued, it's hard to just do because you're so exhausted, but you may not fall asleep. And that's important because sleepiness tends to be a very specific symptom related to some dysfunction in the sleep-wake mechanism, or some problem with sleep, or the amount of sleep, or whatnot. Whereas fatigue emanates from multiple different sources. And so fatigue is a very common complaint in individuals going through or treated for cancer. And so sleepiness may or may not be a component of it. And so when evaluating a patient, I'm always trying to differentiate the difference between those two symptoms. Sleep disturbances in patients with cancer or treated, recently treated, are remarkably common. Anywhere from 30 to 75% of newly diagnosed or recently treated cancer patients have various sleep disturbance or sleep complaints. 31% complain of having trouble with either initiating or maintaining sleep. About nearly 30% have excessive sleepiness, and there's a large percentage of restless leg syndrome, which is a condition. It's actually a neurologic condition, which is characterized by an uncomfortable or unpleasant sensation in your legs that tends to be worse at night than during the day, and it's better with movement and stretching. And so it's a really kind of like it's a very odd sensation when you experience it, but it tends to be worse at night and better with movement, which is different than, say, a neuropathy pain or some other type of pain condition, which is largely present all the time. It usually isn't improved with movement and so forth. And nearly 50% of patients with or recently treated for cancer, 48% of the total prescriptions written were actually for sleep, at least in one study. So it's incredibly common. The risk factors that we see in patients with cancer for sleep is physical complaints. There's pain, there's night sweats and hot flashes due to some of the treatments, shortness of breath depending upon the nature of the cancer that's being treated, diarrhea, frequent nighttime urination. But there's also the obvious psychological stuff that goes on with a diagnosis of cancer and or treatment of cancer, including anxiety and depression and the stress of it. Obstructive sleep apnea is another condition, which is where people struggle with breathing during sleep, which is common in the general population, not just patients with cancer, but it's also another risk factor for having sleep problems. And certainly medications that are treated. Some are sedating that patients use who have been diagnosed with cancer. Some are sedating, some are activating, and so they can actually cause problems with sleep. And then there's other behavioral issues. And so when you're sick, your schedule tends to get kind of out of whack, and you tend to sleep and wake at different times during the day. You spend a lot more time in bed, which makes it sometimes harder to initiate sleep when you need or want to sleep. General activity is decreased, and even timing of medications and lack of light exposure are all things that can impact an individual's sleep, especially when you're dealing with a acute illness that is with some level of at least persistence, as cancer can be. So, what is my approach in dealing with patients who have sleep problems, who've been diagnosed with cancer? And quite honestly, I approach these individuals as I do any person with any neurologic condition, a brain injury, I basically will evaluate these people as if they don't have these problems and try to find really what is the basis for their sleep issues, and then incorporate what they're currently going through, whether it's the treatments, whether it is the psychological and psychosocial stuff that's going on or whatnot. But really, at its core, I find it's far more effective to really approach individuals as if these problems aren't the reason they have these sleep problems, and then circle back to those problems, because usually there is a predisposition to having sleep issues in individuals that is made worse by the circumstance or treatments and whatnot. And it is incredibly common in my clinic where sleep problems will emerge after a prolonged illness or hospitalization or major surgery. And those sleep problems usually were triggered by that acute event, but there's generally, more often than not, predisposing biological aspects of those individuals that it makes it more likely for sleep problems to emerge. So I'm going to not try to spend too much time, but I think this is really an important foundation for everybody to understand, which is kind of like, let's just talk about sleep. Like, what is it? We spend a third of our life doing it, and most people don't know much about it. So let me just kind of quickly run through the science behind sleep and what my beliefs are about sleep, which is, number one, at its core, it is a biologic process. It's a neurobiologic shift that happens in our brain when we fall asleep and while we are sleeping. And there are behaviors that are sleep promoting or sleep prohibitive. But at the core, it's a biologically mediated process. And it's a very active process. It's not a passive process, which, years past, we used to think people would just suddenly become sort of inert when they fell asleep and everything would just kind of stop, and then we would wake up and then life would start again and our biology would start again. But that's not the case at all. There are distinct physiologic changes, different neurochemical shifts, and activation and or deactivation of parts of our brain and pathways in our brain. And there's certainly different states even within sleep, from non-REM sleep and REM sleep, which is dreaming sleep. It's non-REM sleep is very different from REM sleep, which is very different from being awake. And these are all neurobiologic mediated states that creates a state of consciousness by virtue of the activation or activity of our brain. So, and even the behavioral aspects of sleep, when we talk about falling asleep and you get into a quiet meditative state, that behavioral state that you just achieved has actually changed the neurobiologic landscape of your brain. And so the behavior facilitates sleep by changing the neurobiologic processes that make it ultimately a fertile landscape for sleep to take place. And so, it's a fascinating interplay between behavior and biology. And really, it's very hard to sleep if you are not in a behavioral state which is conducive for sleep. And so understanding the behavioral aspects of it are important, but also understanding that ultimately the neurobiologic landscape that which your behaviors are being engaged is ultimately going to determine how easy you fall asleep, how well you sleep, and how you feel upon awakening. So, we think of it, the behaviors are just, it's alternating with wake, meaning we sleep and then we wake, we change our posture. This raised threshold for sensory stimuli is just, it takes more, if someone pokes you when you're in deep sleep, you're not going to respond unless they poke you really, really hard. And so there's a higher level of arousal threshold, meaning it takes more to wake you or for you to respond when you're sleeping. And obviously lower levels of motor activity, meaning we're just not moving when we're sleeping. And so there are these neurophysiologic changes as well, where our brain in an awake brain looks very different from a sleep brain in non-REM sleep. And then even in REM sleep, our brain looks even different if we're looking at the electrical activity of it. And in fact, if you look at a brain's, the EEG or the electrical activity of brain in REM sleep, it actually looks almost identical as a brain that's awake. So the activation of our brain during dreaming sleep is really, really high or active. And so it's very, very different. In fact, REM sleep from a brain perspective is almost more akin to being awake than it is to being asleep. But it happens during sleep, so we lump the non-REM and REM sleep into this big broad category of sleep. This here is what's called a hypnogram. And so if you ever have a sleep study done, this is generated after the study has been scored. And this is basically a schematic of the sleep stages and architecture of an individual's sleep. And this would be considered sort of a normal sleep. And so if you'll notice on the far left side of this graph, you see that people start off in bed before they sleep awake. And that's an important thing to keep in mind, because we all start out awake and then we fall asleep. And so there is a transition from wake to sleep, and then we go into stage 1 sleep, which is the light sleep. And about 50% of the time, if someone tries to wake you up from stage 1 sleep, you will say you're not sleeping. So it's hard to really differentiate sometimes being asleep and being awake, but it is for sure sleep. But it's what would be called light sleep. And then we kind of enter into stage 2 sleep. And stage 2 sleep is sort of this unequivocal sleep. If someone wakes you from stage 2 sleep, you know you were asleep. As we move deeper into sleep, deep sleep, and so you'll see on this category, it says S3 and S, which means stages 3 and 4. The new nomenclature is to lump those two stages together into N3 or stage 3 sleep, which is basically deep sleep. So REM sleep is not deep sleep. REM sleep is REM sleep. Deep sleep would be considered stage 3 sleep, and that's the deepest sleep that we have. About 90% of all growth hormone is actually secreted in deep sleep, which is why we see a lot more deep sleep in kids than we do in adults. For that reason as well, that's why we often will see more sleepwalking in kids, because there's such a higher density of deep sleep in kids. But at least the speculative reason why there is more deep sleep in kids is because growth hormone is being secreted during that sleep, and kids have a lot more need or developmentally are secreting a lot more growth hormone as part of the developmental growth of a child. Then we enter into REM sleep, and REM sleep is the unequivocal dream, and dreaming can happen in any stage of sleep. Really, dreaming is thought of mental imagery that occurs during sleep, but the kind of dreams that we have in REM sleep are these bizarre plot lines, and it's clearly it's a very real experience when you're in a dream sleep. In fact, when you're in a dream, it's as real as if you're where you're sitting right now. But the difference is that the reality that's being created is internally generated. And if you look you'll see you start out awake, you go into light sleep and then deep sleep and then dreaming sleep. And then there's an excursion up to lighter sleep. And that's considered a sleep cycle. And usually a sleep cycle lasts for about 90 to 120 minutes. And you'll see that there's about 5 sleep cycles in a normal, healthy adult. Kids, it could be up to 7 or 8, but usually there's about 5. And you also see there's a greater concentration of dreaming sleep as the night progresses, meaning there's more dreaming sleep in the latter third of the night than there is in the first third of the night. And the reason we tend to remember our dreams when we wake up in the morning, we're usually remembering that last dreaming episode. We typically don't remember a lot of dreams because you have to wake up either in the midst of or immediately after a dream to have any recall of the dream or even to know that you dreamed. And so when people tell me they don't dream much, usually it's because they're sleeping well. Sometimes it's they don't sleep well at all, and so they're not getting as much REM sleep. But many times people will have plenty of REM sleep. They just don't wake up at the times where after they're having a dreaming or a REM period. There is a normal as I stated before, that there's this excursion up into light sleep or even to wakefulness. And so waking during sleep is not abnormal. It's the inability to reinitiate sleep quickly, which is abnormal. And so we all wake up 2, 3, 4 times in a given night, even though we may have no recollection of actually waking up, or if we do, it was a brief sort of look at the clock or roll over, but it's not abnormal. And so when people will tell me I wake up 2 or 3 times a night, it's not a problem unless they're not realizing the benefits of sleep. So why do we sleep? Don't know, really. We know what happens if we don't. And in fact, there was this kind of really horrible experiment that was done years ago where they took these rats and they deprived them of sleep entirely. They put these little EEGs on the brain, in their brain, and they fed them, and they let them have activity and so forth, but didn't let them sleep. And those rats would lose their tails and develop lesions and lose hair, and then they would die after about 16, 17 days. And then they said, okay, well, let's see if we just deprive them of just REM sleep, just dreaming sleep. Let them sleep and give them everything else they need, but just don't let them get into REM sleep. The rats still died, but after 43 days. And the same thing happened about the same amount of time if they were allowed to go to REM sleep, but not allowed to go into deep sleep, or stages 3 or 4 and 3 sleep. And so we know that sleep is important. We know the type of sleep that we get is crucial to the survival of our organism. And we also know what the consequences of not sleeping are, which is we all feel terrible if we don't get good sleep. Where our mood is impacted, our memory, our concentration, our focus. It impacts blood pressure control and even metabolic processes like blood sugar regulation and digestion. And pain is even made much worse. In fact, there have been studies that have been shown that you would think if you have a pain problem, that pain makes your sleep worse. And that can certainly happen. But if you look in the literature, it actually shows that the direction is that pain is made worse by poor sleep far more powerfully than poor sleep makes pain worse. So sleep is a crucial part of modulating the central nervous system and spinal cord pathways that send these signals up to our brain. And so without enough sleep, or with sleep deprivation or poor quality sleep, it creates what's called a hyperalgesic state, where your pain is you're more sensitive to pain stimuli. And so your interpretation of pain is much higher if you're not getting adequate sleep. So it's intuitive. We all know if we don't sleep well, we don't feel good. But these are some of the more objective things that have been studied and clearly demonstrated. There have also been large-scale epidemiologic studies that have showed that if you don't get enough sleep, you have a higher risk of developing cardiovascular disease, obesity, diabetes, and all-cause overall cardiovascular mortality actually is impacted. And that's important. But you also have to recognize, and when we say not enough sleep, the threshold is really less than 6 hours of sleep. And in fact, these same studies, interestingly, it showed a U-shaped curve, meaning not only was it that less than 6 hours of sleep showed all these bad outcomes, but more than 9 hours of sleep actually had similar outcomes. So it's important to recognize, though, that these epidemiologic studies are not done in the way that you can demonstrate causality, meaning one thing causes another. It can only demonstrate associations, meaning not enough sleep is associated with all of these things. And those are important things to note, but it also, in my experience, increases the level of anxiety and stress about people who have sleep problems, because they feel like I'm going to die if I don't get enough sleep. And it's not necessarily applicable to everybody in that same way, but rather stresses the importance of getting the amount of sleep that you need. Sleep deprivation has profound effects on people, and safety is an important one. And so a study in 2001 demonstrated that chronic sleep restriction, which was less than 6 hours a night for sequential nights, or 1 night of no sleep, individuals demonstrated reaction times similar to those with blood alcohol levels that are higher than the legal limit. And even a long day, an 18-hour day, demonstrated, or 17 to 19-hour day, the equivalent of blood alcohol, like you've had a drink or two. In other words, just being up for a long time, by the end of the day, you're not, from a reaction time, from a coordination time, from a concentration and a cognitive perspective, you're not fully present necessarily if you haven't gotten enough sleep or have been up for a long period of time. But as I was saying before, associations don't necessarily equal causality. And we'll talk a little bit more about this a little bit later in the talk when I talk about sleep medications, that there's a relationship between insufficient sleep and insomnia and the development of dementia. And those are important associations, and may be applicable for some, but across the board, it's hard to say that this is absolutely the case, because, again, associations does not necessarily equal causality. So, okay, all that's important. So what do we do to optimize our sleep? And what I'm going to go over here is applicable for people with sleep problems, and people even if you don't have sleep problems, but sort of reconciling your sleep with what really, how do you make it the best that it can be in order to realize the greatest benefits from it? There are lots of myths and biases and ignorance around sleep. And we generally think about sleep through this lens of conventional wisdom. And essentially what we're taught, and all the recommendations you read about sleep are saying that sleep is one thing. There's no heterogeneity. There's no differences. We should all be exactly the same. And the reality of it is we are not. Each person is unique in their own biologic basis and regulatory mechanisms of needs and consequences of sleep loss and even timing of sleep, which we're going to talk about, because that is where we need to focus and how do we optimize our sleep. So the areas, and this is something I literally go over multiple times every day with patients, which is talking about reconciling what are your sleep needs? What's the optimal timing of your sleep? What's your brain's central nervous system's capabilities of achieving your 24-hour sleep requirements in a single consolidated nighttime sleep period? And then what are your expectations? Because your expectations are going to guide your behaviors. And your behaviors then may lead to issues if these other points are not being reconciled. And then there's the added influence of other sleep fragmenting conditions. These are conditions that prevent you from being able to get a good night's sleep because your brain's constantly trying to wake you up, like sleep apnea or periodic limb movement disorder, which is where people kick during sleep, or even sleep-related seizures and other things. But then there's also medications and medical conditions which can also negatively impact sleep. And so those are variables that confound sort of the previous points as far as reconciling them, but those are all important pieces here to think about when thinking about your own sleep. Sleep needs vary. This is a graph of just the average sleep duration. Now this is reported duration, this isn't necessarily need, but you can see that the middle graphs, which is your mean or your average, the middle columns are essentially somewhere between 7.5 to 8.5 hours of sleep. And that is the average within a population. But when we talk about what might be considered a normal amount of sleep, that range could be anywhere from 6 to 9 hours. And so that's kind of what we think of as sort of a normal amount. And the question is, where do you fall within that spectrum? And what are your needs? Because there are people who are shorter sleepers, and there are people who are longer sleepers. And there are people who have greater sensitivity to sleep loss and more consequences of sleep loss in terms of the daytime function. And there are those who are less. And so it's important to reconcile that point in order to understand how you should be sleeping in terms of your opportunity for sleep. It is, again, potentially is a neurobiologic process, and it's governed by discrete structures and processes in our central nervous system. But we're taught to think that sleep should uniformly work. We should all go to bed at night, fall asleep quickly, sleep through the night, never wake up rested and feel great. And while that certainly is what would be considered normal, sleep is governed by a sleep mechanism in our central nervous system. And just like any other process in the human body, it can be potentially subject to intrinsic dysfunction, where your brain's ability to attain that 24-hour sleep requirement in a single nighttime sleep period is just not robust enough in order to do so. We see this as part of a normal age-related change in sort of the robustness of our sleep. And so, again, this is a hypnogram, that graph that I previously showed, and you can see this younger individual only has a couple of awakenings, whereas this older individual will have far more frequent awakenings, a lighter sense of sleep, and that's largely just related to likely an age-related decline in the robustness of the sleep mechanism in the absence of any other issues or sleep problems or sleep dysfunction. And so we see that as part of the normal aging process. But, personally, anecdotally in my clinic, I see people who have this, not infrequently. So it's an important thing to kind of think about, but it's, in my mind, it's really a diagnosis of exclusion, meaning you have to look, it's far more likely to be other things than it is going to be loss of the ability of your brain's ability to attain your 24-hour sleep requirements in a nighttime sleep period. So the amount of sleep is crucial to understand, but you also can't reconcile what the amount of sleep you need without also contemplating or reconciling what the right window of sleep is, or what the optimal timing of sleep is. And so this introduces this idea of what's called chronobiology. And chronobiology is essentially the study of timing of biologic functions. And when we talk about biologic rhythms, people start to kind of, lose interest because they start thinking of crystals and new age things and kind of like, kind of wacky medicine that's not based in science, but in truth, it is a biologic. We have multiple biologic processes that follow clear biologic rhythms, and we know that we see this all the time and recognize it. So an ultradian rhythm is a rhythm that functions within or fluctuates within an 18-hour period, and we see this in the REM non-REM alterations, meaning in an individual, a normal sleeper, we see consistent pattern of dreaming sleep and non-dreaming sleep that falls in a fairly reliable manner consistently night after night after night. An infradian rhythm is a period that's more than 24 hours. So the menstrual cycle is one that we all recognize as, and that's governed by rhythmicity and biologic processes that are based upon a timing and intrinsic processes that are being regulated by virtue of the timing. Whereas a circadian rhythm, which is what we're focused on as it relates to sleep, functions within a period around 24 hours. And so our circadian rhythms are essentially our internal body clock. And in humans, our internal clock in a normal individual is a little bit longer than 24 hours. And so let's say it's 24.2. It's been debated as to exactly how long it is, but somewhere between 24.2 to 24.6 hours, right? And so that would mean, in the absence of any schedule, that we would have a tendency to go to bed a little later and wake a little later every night. But by getting up every day at the same time and getting light exposure and engaging in waking behaviors, that entrains is the term, which basically hardwires our clock so that we now can pull it into a 24-hour period. And so for optimal function, our internal bodies have to be synchronized with each other and to the external clock and social rhythms for us to be able to sleep and wake as we really are naturally designed to do so. We have this clock in our brain. We call it the suprachiasmatic nucleus. It sits and resides in our central nervous system, and light is the primary regulator of this clock in our brain. Light will inhibit the activity of it, whereas darkness stimulates the activity. And light, this clock, essentially, if you can follow the path from where the suprachiasmatic nucleus is, you see that ultimately lands on the pineal gland, which is what secretes melatonin. And melatonin is a hormone that our brain secretes that essentially triggers the processes that start sleep and will typically be released about 2 hours before your natural biologic sleep onset time. And so when people take melatonin, essentially what they're doing is taking the hormone, and the question is whether or not they're taking it in alignment with their sleep period or not in alignment with their sleep period. It's not a terribly reliable sleeping pill, but if you take it earlier than your natural melatonin onset, so let's say that you're someone who naturally goes to bed at midnight, which would suggest that your internal melatonin levels are being secreted around 10. And so if you took melatonin around 9, what happens is that if your endogenous melatonin levels are low, melatonin to be more sedating and then can help people fall asleep. And so it's when I talk about melatonin, I'm usually talking about it more as what's called a chronobiotic or a biologic time-setting agent, not as a sleep medication. Nearly every cell in the human body has clock genes, and they modulate the activity of the cell in part by cues received by this master clock in our brain. So these clock genes turn on and off based upon the time that our internal rhythm is following and what our master clock is telling us. And we know this. I mean, if you think about it, cells are grouped together, which then ultimately they differentiate and form organs, right? And so when you so our kidney system, our liver system, our GI system, our cardiovascular system, all of these things are very different while we're sleeping than when we're awake. And so when you're awake, when you should be sleeping, or you wake up in the midst of sleep, you know how it feels that you're biologically not supposed to be awake. And that's because all of these organ systems are essentially designed to be sleeping when you are awake. It's actually been shown that studies have demonstrated higher susceptibility to cancer in individuals whose body clocks are misaligned with their schedule. Shift workers are a particular group that cancer has been shown to have a higher incidence. And that's it. Is it a causal thing? Unclear, but it does raise the question of how much misalignment of an individual's rhythm with their life could be playing a role. And certain medications and even chemotherapeutic agents have been shown to be more effective if administered at different times of the day due to the circadian rhythmicity and variability of gene expression or activity of our cells within a 24-hour period. And so chronotoxicity is a term that's been coined to describe the time-dependent susceptibility of cells to toxic substances. In other words, there are cells may be more susceptible to carcinogens at different times of the day than at others by virtue of the activity of those cells at that time during the day. This, we don't have to spend too much time on this graph, but this is essentially showing the differences of what our body is doing. This S is where we're sleeping, and you can see our body temperature, our cortisol level, our urine volume, our thyroid hormone, our growth hormone. All of these things have a pattern, and so of either decrease or increase while we're sleeping. And if you look, this is where people did not sleep. You could see body temperature is blunted if they didn't go to sleep. Cortisol level is blunted. Urine volume essentially will go up because it should go down while we're sleeping. In other words, sleep plays a crucial role. Growth hormone is not secreted in these biologic processes and how they ultimately function. This model is a model that I use for every single patient that I see in clinic, everyone. And I use this as a basis from which to try to understand an individual's sleep problems. And so bear with me while I go through it, because I think it will, if you can understand it and incorporate it into what you do, you will start to think about your sleep, I think, in a different way. Process S means the homeostatic pressure to sleep. And essentially what that means is the longer we're asleep, the sleepier we get. We call that sleep debt or sleep drive. And we all know that because the longer we're awake, the sleepier we do get. But there's actually a biologic process that is driving that. Whereas with process C is the circadian drive to sleep or to wake, really. And so if it weren't for an opposing process to this process S, we would need to sleep every few hours. And so if you look at this graph, and if you start here, let's say this is at the top here on the far left, you can see that this is wake. And at the top, it's sleep load. And you can see that the sleep load is very low at 9 a.m. And the alerting signal from our brain, which is process C, is not very low. And as the day progresses, you start to see that the load starts to increase. And in parallel, we see the alerting mechanism starting to increase in response to that increased drive. If you look in the middle, there's a graph, there's a line that says alertness level, and you can see how it goes up as the alerting signal is rising in parallel in the sleep load, but you also see a dip, and that dip is in mid-afternoon, and that's the typical kind of sleepiness, post-lunch afternoon sleepiness that we all experience, which is made much worse if we haven't gotten enough sleep, and that's because our sleep load is so much higher. But the reason that occurs is because there's a transient imbalance between our sleep drive and our alerting signal, because our alerting signal tends to naturally wane somewhat in the afternoon, but then we get our second wind. We don't sleep, and all of a sudden we feel wide awake. And why? Because our alerting signal has now kicked up and matched our process S. So at bedtime, essentially, our drive is at its highest, and our alerting signal is at its highest. And how we fall asleep, we quiet that alerting signal somewhat by getting into a quiet meditative state. And the sleep load is allowed to express itself. And then as we sleep, our sleep load drops off because we're sleeping and eliminating that drive. But our alerting signal is dropping off, not because we're sleeping, but because of the timing of our sleep. And so you can see that the alertness level, that pink curve in the middle curve, drops down super low because our alerting signal is essentially at its lowest. So how does that apply to all of us? Well, the timing of sleep versus duration of sleep. So when we talk about timing of sleep, the way that people tend to kind of think about it, at least in our field, is sort of, are you a night owl? Are you an early bird? These are real things that are genetically determined. They're called chronotypes. And chronotypes are essentially our biologic makeup of how genetically determined, and is a trait. It is not a behavior. And contrary to popular belief, if you are truly a night owl, you cannot make yourself a morning person by going to bed early and getting up early, any more so than if you are a white person, you can make yourself a black person by laying in the sun, because these are traits, not behaviors. And so essentially, a lot of what I see is night owls. I call it the night owl versus early bird conundrum, which is our society is not designed for night owls, but they're designed for early birds. But if you are a night owl, that intrinsically is going to create a problem with sleep. And so one way of thinking about this is, let's say I go to bed at 11 and I get up at 7 and I feel pretty good, but suddenly my job changes and I have to get up at 3 in the morning. I could go to bed at 7 p.m. and wake up at 3 in the morning. I am not going to feel, let's just say I sleep through the night. I am not going to feel nearly as good getting 8 hours of sleep and waking up at 3 in the morning than I would feel if I got 8 hours of sleep and woke up at 7 in the morning. And so that is an important thing to think about, because some people will have real problems both falling asleep, staying asleep, and waking up. And really the problem is that they're forced or expect to sleep in a window that they're just not biologically designed to do so. That term is called circadian misalignment. And essentially what circadian misalignment means is that your body clock is not aligned with your life. This is a graph of our core body temperature. And so you'll see our body temperature actually drops about a degree while we're sleeping. And so when our body temperature begins to drop at its steepest point, you can see this biologic sleep onset. That is essentially when we feel sleepy and are ready to sleep. And while we're sleeping, our body temperature drops and reaches down to this lowest point. And in that middle part where it says forbidden zone is essentially where we are at our deepest sleep, and it's the hardest to wake up. And if we are awake, it's really hard. If we're having to stay up all night, it's really hard to stay awake. And so they call it the forbidden zone because that's where we should not be trying to drive or operate heavy machinery or be at the controls of 3 Mile Island or Chernobyl, which is when those accidents occurred, because there were humans behind the controls who were fighting sleep and unable to stay awake, or at least their judgment or potential for error was much higher. You can see the biologic sleep offset occurs as our body temperature is starting to increase. And so when you talk about circadian misalignment, if someone has a behavioral bedtime that is hours before their biologic sleep onset, it's very hard to fall asleep. And if they have to wake up in the middle of their forbidden zone, it's very hard to wake up. And that is something that I see very, very commonly. So one way to also think about this is that there was, before the advent of electricity, there was cultures around the world would have what they call two sleeps. So people would sleep based upon the light-dark cycles, and they would go to bed usually an hour or two after dusk. They would sleep for 3 to 4 hours. They'd be awake for a couple of hours, and then they would go back to sleep and sleep for another few hours. And this was considered entirely normal, so much so that the middle of the night awakening was a time that people would do work by candlelight, or they would have social engagements, or they would have intimacy or sexual encounters with their spouses or whatnot, because this was a wake time that was considered part of the normal day. So why did this occur? Well, it occurred because there was a decoupling of this entire process. I'm sorry, let me go back. So what you'll see is people were going to sleep right after dusk when their sleep drive was high, but their alerting signal had not reached its peak. They would sleep for a few hours and then they would wake up. And when they woke up, their alerting signal was still, I don't think you guys can see my pointer, but if you look down at the bottom of this graph, you can see after the first sleep ends, the alerting signal is at its peak. So they're wide awake. And then they would be awake for a few hours and they would go to sleep when their body temperature reached their lowest point and that forbidden zone was hit, and they would fall back asleep and sleep for another few hours. This is a clinical model of problems with people waking up in the middle of the night and not being able to go back to sleep that I see every day. And it's based upon just purely this timing of sleep. Well, with the advent of electricity, what happened was bedtimes were pushed later, and these two processes now aligned with each other, so people would fall asleep from their sleep drive, their alerting mechanism would drop while they're sleeping, and the inertia of that sleep would keep them asleep until they would wake up. So, shift work, not good for people. Generally, humans are designed to sleep during the night and be awake during the day. And so it creates, for the same reason I just described, we're not designed to be sleeping during the day. And so people often cannot get as much sleep as they need during the day, and often have difficulty staying awake because they're staying awake during their forbidden zone. Now, night owls are far better designed for night shift work than early birds, because for them to stay up a couple of hours later and is much easier than it is for an early bird who's trying to stay up way past their biologic sleep period. And we know that this is associated with fatigue-related single truck accidents, where you can see how many greater accidents, when we say single vehicle truck accidents, meaning these are people who fell asleep and drove off the road, you can see how incredibly frequent it occurs between 3 a.m. and 7 a.m. and how it drops markedly off during the day. So how much time do I have? Okay. Let me just cover some sleep disorders here, and I'm not getting too in depth, but I want to touch on these things just so that y'all are aware of it, and then we'll take some questions. People tend to think that sleep medicine is sleep apnea. Sleep apnea, as you can see, is one diagnosis of multiple different diagnoses. So recognizing that when I see patients with symptoms. They come in with complaints. They don't have they're not necessarily diagnosed with something. They have trouble falling asleep, staying asleep, falling back asleep, waking up tired, feeling sleepy, do crazy things during sleep, etc. And so evaluating patients with sleep disorders or sleep complaints is you have to kind of think about the whole breadth of potential things that could potentially be causing it. And that includes the insomnia disorders, the sleep fragmenting disorders, the circadian rhythm disorders, the central nervous system hypersomnia syndromes. These are people's who are excessively sleepy because their brain's ability to attain and sustain a waking state is limited because of some central nervous system dysfunction. There's also sleep-related movement disorders, and parasomnias are basically abnormal behaviors during sleep. Oh, and then there's the pediatric, which we won't get into too much. Insomnia, remarkably common. 30 to 36% of the general population report at least one insomnia symptom on a chronic basis. 10 to 15% of the population have chronic insomnia symptoms and associated daytime consequences. And that's important because daytime consequences is what essentially makes the diagnosis of insomnia. In other words, you could sleep poorly, but if you feel fine, you could argue that that's not formally insomnia because you're still realizing the benefits of sleep. But a 2002 survey performed in a primary care setting found 50% of patients in that practice had intermittent insomnia, where 19% reported chronic. So it's remarkably common. A model of insomnia is essentially, if you think about it, people have some predisposition, which is the far left little square block, and then there is a precipitating factor. And so if you'll see across the middle, there's an insomnia threshold or insomnia intensity. So we all sort of live below this threshold until there's a precipitating factor. Anybody could have insomnia if you put enough stress on them. And so they will essentially go up above the insomnia threshold and have trouble sleeping. But if there are perpetuating factors, and those are things that either the stress continues, but more often than not, it's the behavioral response to not sleeping and the reinforcement of negative associated behaviors and non-constructive behaviors that in essence prevent sleep from happening, it can then become a chronic problem. And so this is what they call the 3P model of the evolution of insomnia. And I believe in it, but I also believe that there's a real biologic basis for these problems to emerge. And some of the basis of this biologic process is rooted in these PET imaging studies. And so PET imaging studies are essentially people are injected with some type of substance that is linked to glucose setting. And so the brain uses sugar as part of its metabolism, and it fuels the activity of the brain. So what they can do is they can see where is the brain active in an individual at any given time by virtue of the sugar metabolism that brain uses. And so what you're seeing here, where it's lit up on each of these images, is where you see they compare people with insomnia to people without insomnia, both during wake and during sleep. And what you'll see is where it's lit up is where individuals with insomnia's brains are literally overactive as compared to those without insomnia. And those generally involve the arousal system, the part of our brain for wakefulness, the emotional regulatory system, and even the cognitive system are all overly active, both during wake and sleep. And so when an individual with insomnia says they can't shut their brain off, that is a biologic problem and not a behavioral one, because they literally cannot turn their brain off because it's biologically overactive. Now, one important point to differentiate, though, is insomnia a symptom or is insomnia the condition? And so if someone can't sleep at night, can't fall asleep, they can't shut their brain off, lay in bed, toss and turn, all I can do is think, but then they can't have a difficult time waking up, and then they nap during the day. Well, to me, that's insomnia is a symptom, because if they can sleep in a 24-hour period, just not when they want to or need to or expect to, that's usually more likely a circadian rhythm issue and not a, quote, insomnia issue. Because my patients who have what I call true insomnia, they never get sleepy. They could stay there for 24 hours and they still won't get sleepy. They're tired, they're exhausted. The term wired but tired is a term that's usually thrown around in these individuals because they cannot shut their brain down because of this hyper metabolic or hyper aroused state that their brain is chronically in. And so those are two different sort of symptom complexes that I'm looking for to differentiate, because I will have a very different approach towards those two types of individuals. So let's just touch on sleep medications and dementia, because that is a hot button topic. There have been a number of studies that have shown that sleep medications increase the likelihood of, or increase the risk of, developing dementia. And while I think those studies are important because it highlights the potential risk of using sleep medications, recklessly or without oversight, but unfortunately, those studies are not done in a way that can demonstrate causality. Usually, these studies have been done retrospectively. They've looked at pharmacy records. They haven't been able to perform a placebo-controlled prospective study to demonstrate causality, because that's just a very difficult study to do in this type of setting, and it has to be done over the course of like 20 years or so. But the problem really is that people with dementia have more insomnia and sleep problems than people without dementia. And studies vary but some studies have showed anywhere from 30 to 70% even have demonstrated complaints of sleep problems, sleep disturbances, irregular sleep-wake cycles, nighttime awakenings. And part of it is just the probable intrinsic deterioration of the degenerative process of dementia that's predisposing these individuals to sleep problems. So essentially, my interpretation of these studies are that these are people who are being treated for insomnia more than people who are not. And so when you look at age and gender matched controls, people who don't have dementia, you're going to have less sleep problems in that population than you are in the dementia population. And so in the dementia population, you're going to be treated more, and therefore you're going to see more dementia with that. Now, I can't say that that's absolutely the case, but the reality of it is that if you look at a group of people who have died from cardiovascular disease, and you compare them to age and gender matched controls who don't have cardiovascular disease, you're going to find that the people with the cardiovascular death group had more high blood pressure, because we know that high blood pressure is a cardiovascular risk factor. It increases the risk of cardiovascular disease and then ultimately cardiovascular death. So then do we make the assumption that blood pressure medications are killing all these people, because far more people were on blood pressure medications who died from cardiovascular disease than people who don't have cardiovascular disease? And of course we don't, because we know that blood pressure medications are treating something that potentially can increase the risk. In the same way, you can't necessarily make the conclusion that sleep medications are causing dementia, because these are people who are being treated for insomnia more than people who don't have dementia. That said, we just do not know the risk. And so I counsel patients every time, those who I have on chronic sleep medications, and I've got a ton of them. And I'm not saying that it's good. I don't think it is good. I don't think blood pressure medications are good unless you need them. And so when sleeping medications are an option, not the only option, but an option, and one that is the most beneficial for that individual, and other treatments do not work very effectively, I would argue the benefit of using sleep medications far outweighs the potential theoretic risk. But that's a case by case, and I take that as a case by case, as well as an individual's motivation and preferences, and ultimately everything else we've discussed thus far. And so, there's other things you've probably read about sleep hygiene. It's not an effective standalone treatment for insomnia. So doing all the things that you should do before you go to sleep does not fix insomnia, but it is a crucial or a critical part of the whole process of the behavioral management of insomnia. And so, these points here that I'm reviewing quickly, obviously, is, just kind of don't do dumb things, and try to maintain the integrity of the sleep location and environment, which will help create the landscape potentially for sleep to happen. Stimulus control is the idea that decreasing the arousal response to the bed and sleep process can help reassociate the bed as a place to sleep. So we kind of use the term, the phrase the bed is only for sleep and sex, and so you shouldn't watch TV in bed, and you should read in bed, you shouldn't do all these things. Well, I mean, I think that is true, but I also have patients who say, I can't fall asleep unless I have the TV on, If I have TV on, I can fall asleep in 20 minutes, but if without the TV, I'm up all night. Well, then leave the TV on. I mean, it's not the best association, but it's at the same time, ideally it's on a timer so that if you wake up in the middle of the night, you're not then drawn to the TV and now you're up watching TV for the rest of the night. But essentially, the idea here is that the more time you spend in bed not sleeping, the stronger the association with the bed becomes a place not to sleep. And so by limiting the activity and increasing the association of the bed as a place to sleep by pretty much spending most of the time that you're in bed sleeping, it helps to recondition that into a positive light. And then there's CBTI, which is cognitive behavioral therapy for insomnia. And this incorporates all of these things, as well as some what's called cognitive restructuring, which is kind of just reframing expectations and beliefs about sleep and sleep loss, and reconciling all of these things we talked about: sleep needs, sleep capabilities, timing of sleep, and all of these things incorporated into your whole process as far as how you approach sleep. If you look in the literature and you look at the recommendations, CBTI is recommended over sleep medications, and it is a part of every patient I treat with insomnia. I am incorporating CBTI components into the management of that individual. My own personal experience is that CBTI is effective for a small percentage of individuals, and that there are many patients that it's not terribly effective for. But I do think that without incorporating CBTI into the management, even so, if I'm prescribing sleep medications, those sleep medications are going to be far more effective if you are engaging and incorporating all of these concepts into your process, as opposed to not, and just relying upon a medication to put you to sleep, because ultimately the medications lose their effect, and tolerance or side effects or whatnot can occur. And so I think I've run out of time here, so let me just quickly talk about sleep apnea. This is where snoring is the first step, where throat muscles relax. Sleep apnea is where the tissue in your throat narrows because of relaxation of those muscles and blocks the airflow, and thus causes sleep fragmentation, sleep disruption. People wake more during the night, wake more tired, feel sleepy. It's remarkably prevalent in the population. It's been estimated 1 in 5 individuals, adult individuals in the US, have some degree of sleep apnea. In cardiovascular disease, it's been estimated that 1 in 3 or 1 in 2 patients have sleep apnea, and has a strong relation with the development of cardiovascular disease: high blood pressure, strokes, heart attacks, heart failure, heart arrhythmias. All of these things sleep apnea makes more likely to occur, makes harder to treat. It is the most common treatable cause of high blood pressure as well. And so I see lots of patients who are referred to me from the cardiovascular groups because of the comorbidity and the impact of this condition in those comorbid conditions. I'm going to close the talk here. I have a ton of slides here on the sleep breathing disorders, but I'm not going to get too much into it, so we have time for some questions.
Thank you so much, Dr. Leibowitz, for doing this for us today. I did have a question about any recommendations you have for people having a lot of anxiety right now, maybe watching the news a lot and having difficulty sleeping or just falling asleep at night. Any recommendations other than the standard, what you've talked about earlier?
So my number one recommendation is, if you are not sleepy, don't go to bed. Mm-hmm. Which sounds intuitive, but most people don't follow that. We tend to think of, I have to have a regular bedtime, I have to go to bed at the same time every night, because that's what the recommendations are. And while that is somewhat true, it's actually waking up regularly at the same time and assuming that wake time is actually in alignment with your biologic sleep offset time. If you get up around the same time every day, you tend to fall asleep around the same time every night. It's probably a good idea to stay off of the news in the evenings, because that serves nothing but to heighten levels of anxiety and fear. The other thing that I will frequently recommend, and this is a tool that anybody can engage in, is something that's been called a worry time. And what a worry time is essentially is you sit down with a pen and paper and you make a list, everything that you are worried about, as little or as big as you can come up with. And you have to kind of categorize it as, okay, things I can do, and things I can control, and things I can't control. And so, there are things certainly in the setting of this pandemic, that we can't control, But there are things that we can control, and because there is a sense of helplessness that we all feel, and you have to, on some level, let go of that helplessness, but then control the things that you can. And so make a list and then come up and then draw a column down the paper and have a to do. What am I going to do? The one thing I'm going to do tomorrow morning to deal with that problem. And what that essentially does is it allows you to ground your worries and to kind of come up with an action plan. And let's just say, okay, I'm worried about being able to pay my mortgage. Okay, well, tomorrow morning I'm going to call the bank and get a line of credit. Okay, maybe you will, maybe you won't, maybe whatever, but at least you have a thing that you're going to do to try. So when you get into bed and you start worrying about that, you could say, wait, I've already worried about that. And there's nothing I can do to change that. I've got a plan. So the way I think of it is that we're reading the book of life all day, right? When we walk into our bedroom, that bedroom should be protected. And all of a sudden the book is closed. But if you've done this worry time, you've essentially put a place marker in your book. So in the morning, you're going to pick it back up, open up the book, and everything's going to be laid out and structured for you. So you can literally walk away and close the book the moment you walk into your room. It's actually remarkably helpful for some, especially if people worry a lot about life when they're trying to go to sleep, as opposed to worrying about sleep, which is a different problem.
That's great. Thank you. Very helpful. Another question I see, do you recommend meditation and breathing exercises before bedtime to help relax?
1,000%. Meditation, of which breathing exercises is a means with which to help try to get into a meditative state. Meditation, if you look at an EEG or a brain activity of an individual while they're meditating, you will see a slowing of the brain activity. And that is moving towards a state of sleep. And so by allowing it, not to mention the de-stressing that it provides and sort of the therapeutic benefits of meditation in and of itself, but by getting into a meditative state, you are calming the activity of your brain, quieting it, and creating a more fertile landscape for sleep to actually happen.
Okay. Any thoughts on apps like Headspace or or do you think that's helpful to be on those apps, or can the screen time still kind of disrupt sleep?
Generally, those apps are voice guided. So you're not looking at the screen, you turn it on and just listen. And so, yeah, I think some people find that the Headspace voice is annoying and some love it. But I think some people love it. And, but there's a ton of them and they're great. Yeah.
And advice on latest in day coffee in comparison to bedtime. When could you have your last coffee?
I usually say before noon.
Okay. Do you recommend taking melatonin or Benadryl to help getting to sleep?
Melatonin, yeah, I mean, it can be helpful for some. It's not necessarily for everyone. It's generally fairly harmless. The only issue being is it's considered a nutritional supplement by the FDA, so it doesn't have the highest level of regulation. I don't recommend Benadryl, and I don't recommend over-the-counter medications routinely. Largely, I personally think over-the-counter medications are more toxic potentially than even prescription medications. I think 25 milligrams of Benadryl isn't the worst thing in the world, but at the same time, usually tolerance emerges over time. And the biggest issue that I have with Benadryl or over-the-counter sleep meds is they tend to leave people hungover and groggy. And, the purpose of sleep is not sleep. The purpose of sleep is wake. And so if we sleep all night, but then we feel worse as a result of having taken something, then have you really achieved anything? And so the biggest issue with what I see with over-the-counter is that tolerance emerges and people are taking 3, 4, 5 of them. And that's where you start to really see potential risk and side effects associated with them.
What level of exercise do you recommend to help with sleep?
Well, it's been shown that aerobic activity, so 30 minutes or more, a few days a week of getting your heart rate elevated, can be of benefit. It makes sleep quality better. But the reality of it is that people who exercise regularly report that they sleep better. I have rarely ever seen, rarely see people actually fix their sleep problems or make them sleep better by exercising more. I think, because
Mm-hmm.
thinking of it this way, exercise can create physical fatigue, but it doesn't create sleepiness necessarily. And
Mm-hmm.
so it's not, but, and exercising too late in the night can also activate you more, make it harder to sleep.
Mm-hmm. Okay, last question. What about valerian in the tea form?
So Valerian, so the biggest issue, again, it's similar to melatonin, is that it's not regulated. You don't know what you're getting when you take it. Has activity that binds to receptors that are similar to sort of like the benzodiazepine. So it can be sedating, and it can be effective and helpful. And so I don't recommend it from the standpoint just because there's not a lot of evidence to support its use, and safety is probably the biggest part. But it's sort of like any other herbal remedy. It's just not, we don't have the FDA regulation of it. But for some people, it's shown to be helpful and effective. You just have to be careful about the dosages, and you just don't know what you're necessarily taking when you're taking it.
All right. Well, thank you so much. That was great information and very helpful. We're saying lots of thank yous in the chat box. So we appreciate you taking your time for this presentation, and thank you so much for sharing your knowledge with the cancer support community. We appreciate it.
It was my pleasure. I hope it was helpful.
All right, everyone, have a wonderful day.
Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org, or follow us on Facebook. We'll be sharing additional information on upcoming programs.